So when we talk about where we get our info, obviously this is your pharmacology Bible is this. Now I did create a Google link for this, which means as we find errors or as I can kind of change. Some of these meds are new for me teaching AEMTs. It's strange to kind of teach them the AEMT, so some of this is new, is the point. We're going to kind of jump right back into you being close. So
Do you have one for now?
I do, because I'm so smart and I remembered your email that you were coming. Boom. That sounded true, right? Sold it? Okay. So this is your Bible for that. The link is always better. All the links are always better because I can update in real time. If you're like, wait, you say this here but that there, I'm like, oops, I'll make the correction. So be a little careful when you say like, oh man, I've got these. In fact, if you're going to go through the effort of like cutting them and laminating and printing them, I actually recommend that you wait on that for a week or two because we'll start running scenarios that incorporate these, and that's really where we're going to be like, wait, it says Catormalac, that's wrong. I'm like, oops, and I'll just correct it. So do as you want. So your primary source of information while you're here is going to be your book and is going to be these drug cards. This is an abridged and abbreviated version of that. But never, again, this should be the start of your education, not the end of it. Meaning your medical director is going to have a lot of say in what you can and can't do. Is that my drug cards on your phone? Is that where you don't care about your cat, and neither do you. So, all right. All right. Protocols, standing orders, but also the physical boxes. You would not believe the amount of times where I'm talking to some peer of mine, and they're like, really, it's like that? How do you know that? I'm like, the box says it. I just looked at the box. It had a little card in there with some information on it. There's a staggering amount of information in there. Like, if I were to ask you dextrose, like, as far as what catheter or where to do it, as far as like proximal or distal,
Have I read that?
No, not that you read it, but if you were to like give a lesson to them, in fact, to say, hey, when you do dextrose, it's very common for people to say you want a large bore IV, and you want it to be distal, not proximal, these kind of things. Does that all sound true? Okay, but the box says the opposite of that.
What?
Yeah, the box is like, you should really use distal with a low bore and da-da-da, yeah. Mm-hmm.
Why?
My guess is because they are understanding that if it's wrong and you give too much, it becomes bad faster. I don't really know, but the point I'm making is like, I was a bit of an anomaly in the field for knowing that. I'm like, I don't know, set it on the back of the cereal box. This is what we do. So, but at the end of the day, regardless of drug inserts, regardless of your drug cards, make sure that you're adhering to like Mr. King's clinical protocols or whatever, or as well as the place that you're working at, right? Now, they talk about all of these different things, and you'll find them in your book, the 10 rights. Is 10 rights new to you, or is that now? You know that is new?
Yeah.
Because you knew like 5-ish? 6? Okay,
6.
every year it's like there's more rights. I don't know if this is true, so carefully with this, but I feel like if I'm going to write a test question about it, I'm not going to ask any of the last 6, or whatever numbers carry the 1 and then divide by 2 or whatever. But these are the things I care about primarily. And I care about them insofar as I might ask you how, what the 5 rights are, 6 rights, or whether or not to verify it's a right dose versus the right route. And these are all concepts that you should be doing. It's like, I mean, you do it every day. You sit down for lunch, you want to make sure that you're eating human food, not dog food, right? I mean, in most cases. But how do we do this? MedChecks does most of this for us, and that's what I really care about, that we're doing a med check every time. Can you do a med check without a partner?
Yeah.
Mm-hmm. Yes, you can, and you should, in fact, right? What I don't want you saying is I'm running this call alone, I didn't have a partner, so therefore I can't do a med check, so I no longer care about indications, contraindications, or any of that. It's like, whoa, right? Now, what do I want to say about this? It should become habit. It's what we call, have we talked about this term, sterile moments? Have we heard this term, sterile moments? There are a couple of sterile moments that happen in the field, 2 of which I can think offhand. One is when you're loading a stretcher. The second is when you're giving a med. And these moments are where nothing in the world matters except for this activity. I don't care that my patient's heart just stopped beating. I don't care that they stopped breathing. I don't care about your cat or whatever the case is. I'm loading them into the ambulance. That is the most important focus right now, is getting them safely into the ambulance, because what does it matter if I pitch them over and everything changes, right? Another one of those is during administration of medication. Is this the right thing? Is it, hey, like, we need to ask history, we need to get a DNR, we need all these things, and it's like, okay, if I'm going to give this med, then I need to focus solely on this. And so you just get in this habit of just, you allergic to anything? No? Okay, so I'm gonna give you some Zofran here. You're not allergic to that, right? I look at it, it says Zofran, it says 0.5. 0.5 is right, 0.5 milligrams, okay, right? You just need to be in the habit of consistently checking yourself. We do it once in a med check, but there's no reason why you shouldn't, as you're drawing it up, go through it, as you're administering the medication, again, just verifying, is this the right med? I remember I almost put atropine in a dude's nose once, because we had changed boxes or something. They had changed, it's like, usually it's like purple and it was yellow now because we changed manufacturers or something, so I went to get Narcan and grabbed atropine. And just by habit, I was just going to spray it and I put it in the nose and I was like, yeah, okay, so Narcan, whatever, and I'm like, right, and I look over, I'm like, that says atropine. But it was just because I asked myself, like, is this the right med? I was just so used to years of associating the color that I was like, I don't know what that would do. Now I want to try, but, not in my scope. So I just didn't document it. No, and I didn't do it. All right. So we're gonna go briefly through this. This should be one of those things where if you're like, I don't really remember the second or third step of med check, I expect you to. So we're gonna blast through this essentially. What's the next step here? I call out for med check and they say, round, bravo, 1, 2, 4, whatever makes you feel good. We wanna go through these things, right? All right, well, I'm gonna give 4 milligrams of Imagedron through an IV because of butt pain, or whatever the case is, right? We just want to go through the list. Why are we doing this? Why are we even doing this?
To make sure you're not giving the wrong medication for the wrong thing.
Yeah, because if you say it out loud, somebody will be like, oh, that was a crazy thing, Imagedron rectally? That makes no sense, right? In fact, it's a very important study tool because all the time I'll say, well, hey, I know you're struggling with cardiology. Why don't you sit down and just tell me what you know? What is the difference between the atrial and ventricle? What is the intrinsic rate for the Purkinje fibers? And they'll say crazy things. I'm like, here's how I know you don't study with anyone. Because if you just said that out loud, eventually it'd have been like, that was nonsense you just said, right? And so part of that is just saying it out loud. In fact, life lesson, I suppose, one of the most important ways to process your own trauma and grief is to say it, right? We find if you don't express it, then you plant it like a seed and it grows into this super wicked tree. It bears fruit that you eat and die from, right? So part of that is just bringing it out into the open, and we do that here with meds. The follow-up to that will be either you saying, I mean literally out loud, all right, ma'am, I'm gonna go ahead and give you 324 of aspirin by mouth. Of course, we're doing that for chest pain, okay? And then you ask yourself, any contraindications for this? And you need to do this when? Half the time, some of the time, all the time. All the time with every med. All the time. We saw this in practicals a lot, where people would be like, it's just aspirin, I'm just gonna ask about, I don't know, allergies. Fail, right? Because some medications, especially now, is moving to AEMT because we're going through faster absorption rates and different medications that will affect people, the contraindications become detrimental, right? We need to make sure we're asking that. Then we state it and discuss it essentially. Contraindications, and you just list them, right? And ideally your partner will say, oh, you said in administering nitro, you mentioned the ED drugs, you mentioned no hypotension, but we don't know his heart rate yet. Is heart rate possible contraindication for nitro? Mm-hmm. Okay, great. So that's where your partner would say, oh, wait, we didn't talk about heart rate. Then you might say, well, actually, I don't know his heart rate. I'm really glad we had this talk, right? And so they, parapraxis is what they call that. Freudian slip, anyway. Anyways, no contraindications. I think it's like 2 people got it. That's good. Anyways, I don't know why they think that about me. No contraindications, state it and discuss it, right? It's very, very important. We put this little BK crown up here, the king, right? Because even though someone's assisting you in it, in the med check, whose responsibility is the wrong answer or the right answer? Person giving the meds, right? And that goes back to that Colorado thing we talked about. We had 2 paramedics on scene. One of them threw the med to the other. That guy gave it, and then he got 2 counts. He's going to do like 10 years instead of 6 because he was the one that gave it. You got something?
Yeah. Part of that sterile moment that Mr. Farron was talking about also includes that second provider, second practitioner. Quite often you'll be in the back of a truck, and I'm guilty of it myself, right? I'm like, I don't know, Zofran sounds good. And I'll have a student like, all right, med check. I'm like, yeah, whatever, dude, Zofran. And I was typing. That second provider is just as important. While you're still legally liable for the person pushing the plunger, that second provider still needs to be there. And if that provider isn't there mentally, right, they're like, whatever, dude, just push it, Zofran, type. It's okay to do what he just said, that entire med check with yourself, talking through the contraindications and the indications.
Yeah, and again, in that Colorado example, we don't know what kind of conversation those two medics had. It is entirely possible that no medication was thrown, that like if Mr. Simmons and I were working together, I never said a word to him, I just drew up ketamine and administered it. And he still gets 6 years, because he's a medic, and that med was given. So as you write your reports and dismiss, whatever, I'm like, just know that you can be held accountable if it's in your scope. If he was an AEMT, he would not have been held accountable because ketamine is not in his scope. He would not have gone to prison for it. So we don't know what they said. They might not have talked at all. Here's your drug cards. We're somewhat familiar with this setup already. Blending the mechanism and the class at the top. I try to group those because sometimes they're indistinguishable. You know, it's much like Trinity was jokingly saying earlier, you know, well, it's a vasodilator because it dilates your vasos. It's like, I mean, some of the meds are just that simple, you know. It's a pain reducer that is an analgesic. Like, okay. We just want to briefly go over this. Also, you know, never miss a chance to show Mr. Dreamy, Jake Gyllenhaal here, but we'll talk about the drug name, its classification, mechanism of action, so on and so forth. When I talk about pharmacokinetics, what is pharmacokinetics? Man, I gotta get the name of your EMT instructor. This is essentially how the kinetics, like kinesthetic movement, is the movement of the medication. It's how your body absorbs it, it's how your body processes it, it's really how the medication is being transported and absorbed and utilized in your body. We don't talk a whole lot about it in this class because, quite frankly, I don't value that information a ton. There's little things like, does anybody know, let's say, if you know, you'll have to give me the nose. Any mamas will have to give me the nose here instead of answering. But if you've got a 2-year-old that has a fever, do you give them Motrin or Tylenol? You can't play either, Tina.
You get both. You alternate between the two.
Sure, well, you're kind of a mama, right? Yeah, like right, so why is it? Why with pediatrics do we not just say, well, just keep giving them Tylenol or keep giving them Motrin? Why do you swap every 4 hours? They are smaller. That's you're on your way to it. They have smaller bodies, therefore they have smaller everything, right? And they're just big dumb babies. They don't know how to live yet, right? Their livers suck, their kidneys suck, and that's not ultimately true. But the point is it comes down to bioavailability. Like how it's processed. If Motrin is largely processed in the stomach, because too much Motrin will give me stomach ulcers, and Tylenol or acetaminophen is largely processed in the liver, right, which can give me liver failure with too much, we want to make sure that we're just kind of swapping in between. Whereas if you get old enough, you can just take Motrin every 4 to 6 hours because your body is able to handle it, your bioavailability is likely less in some cases. So anyway, the point is that would be a discussion of the pharmacokinetics of those medications. But it's not something that we largely include, partly due to our limited time frame. And in fact, I can't really think of many instances it comes up, except for the fact if I show up, we show up as AEMTs, I say, hey mama, a baby had a seizure today. That might be a fever. Did you give any meds? She says, yeah. And I say, oh, okay, well, what did you give? She says Motrin. I'm like, oh, okay, then I'm just gonna go ahead and give Tylenol, but I'm probably gonna wait 4 hours if you already gave that med. If she said, I gave Tylenol, but I gave it 4 hours ago, I'm now not giving Tylenol, even though it's been 4 hours, because you have to swap them. So the pharmacokinetics doesn't come into play a lot for us in this class, but that's one example of where that would occur. I don't yet know how we're gonna do drugs. I think I would like to see where we come in the morning and we just do like a drug scenario quiz where I'm like, hey, you've responded to this scenario, what medication, how would you give it, and so forth. And so it'll require you to get the right dose and these things, and we'll discuss it. Before we were kind of just like once a course doing a full tiny farm thing. I might move into that. I'd like to see us doing substantially more work with methodology and application of that. We'll see. Make sure that you know these differences here. These are certainly registered questions I could see popping up, the difference between which of these, big distinction here being generic names not capitalized. And for your reference, I'm moving quickly through this stuff, whereas when we went in EMT, this is literally the same slide, and we went kind of line by line by line, whereas now I'm just saying, hey, if none of this is obvious, all this will be uploaded on Google Slides, whatever, Google. If you don't know that, if this isn't obvious to you, then you should do your own work there, because I've got plenty more stuff to talk to you that does not involve this. Of course, using nitrostat here, its chemical name listed as this trimethylpropane. Generic nitroglycerin, again, remembering that it's a lowercase n in general. Trade name being nitrostat, that's how they market it, so you can have nitro sold by several companies. And its official name, which could either be this glycyltrinonitrate or the nitroglycerin sublingual tablets, USPs. So USPs usually listed after official name. Okay, we talked about it a bit already. Without using the terms vasodilator, why would we assist patients in taking their nitroglycerin? Oh no, this might be the wrong. We don't assist anymore.
We can give.
We administer. Yeah, I thought I'd change this, but we'll see. Hopefully I'm on the right one. But why would we administer nitroglycerin?
To reduce preload.
Reduces preload is a good one, but let's start with indication.
Chest pain,
Chest
non-traumatic.
pain. Non-traumatic chest pain, sure, right? Non-traumatic chest pain. As AEMTs, we're going to give it for another reason.
Pulmonary edema.
Pulmonary edema, right? Very good. So it decreases blood flow inside the heart chambers. Here's kind of my question. It decreases blood flow inside the heart chambers through vasodilation, meaning reducing preload, right? What's a major vein going back to my heart? Right? Vena cava. Nitro dilates vessels, arteries and veins. It's particularly good at dilating venous circulation. If I have a vasodilation experience, what happens to the pressure returning to my heart? It lowers, right? So I have less pressure, therefore less fluid, hence the reduction in preload. Why do we give nitro? Okay, vasodilation, okay, preload. Why are we giving nitro? Why does preload and vasodilation, why do these things benefit us? Why do I give nitro? Explain it to me like I'm not in the medical field.
Your heart's having a hard time functioning on its own.
So that with less preload, we're working less, right? We're now forcing less against it. That is a very good answer. There's also suspicion, still in theory, that if I've got like atherosclerosis or a clot that causing dilation will allow more blood to flow through it, okay? That's also a possibility. But what's happening here is that not only is it causing a reduction of preload, it's also causing vasodilation of arteries, specifically coronary arteries, which is allowing more blood to flow into the myocardium as opposed to in the chambers. So it's kind of a mixed bag there where you might be like, how is a reduced preload good? Less blood to the heart is bad. Less blood pumped out is bad. And it depends on the case, but that can be true. The point here is that we're learning about nitro is that less blood is coming back to the heart, less blood is being utilized by the heart, but it's also increasing the amount that the coronary arteries can perfuse into the myocardium essentially at the same time, right? Now this becomes important understanding exactly how nitroglycerin works, because soon we're going to have to understand why we get pulmonary edema explicitly, and why, again, that the answer to the question of why are we putting them on CPAP is most importantly reduction of preload, not specifically to push fluid out, right? And so this is kind of what I was talking about here, just a reminder of what we're talking about. And if we've got a clot such as this and I cause vasodilation, in theory, more blood can then get around this. So even though it's a reduction of preload because of vasodilation, more blood is actually coming in because it's getting around the clot, in theory. Now, if you had to choose, if you're making the decision between giving aspirin and nitro to a patient, what do you choose?
Aspirin.
Why?
Because it's more.
Because it saves lives.
Yeah, it's proven to actually.
Yeah, King says that. I say about, it's like 25-ish%, I forget the number, 23.5. The AHA is the article, it's funny, we interpret that article separately. The point is a bunch. The point is, is that other than oxygen, we don't have a better life-saving medication unless you count saline, right? So, err on the side of giving aspirin. What do I always say? If you're on the fence about giving nitro, don't. It's not proven to save lives, right? I'm not going to fail you on a practical because you didn't give nitro when you should, but I will definitely fail you on a practical if you give nitro and it kills you, right? The clot's not the only thing. Of course, we talk about this. What's this called here? It's plaque buildup. What's the term, fancy term for that? Atherosclerosis. That's right. Right? And so vasodilation would be good for them as well because in theory, it allows more blood to flow around it from the vasodilation and the like. In that case, it being coronary. All right. Tina, what's the class for nitro?
The action is a dilator.
Sure. Oh, I don't know the order. Let's just go.
Nope.
I forgot to check the animation order. Vasodilator. Great. What does that mean? Dilates vessels. Got it. Tony.
The hose is the larger diameter.
That's right. I'll take it. Tony, we talk about indication, chest pain and discomfort. Give me a scenario where you might give somebody nitro, but they did not say, my chest hurts, or I am uncomfortable. What's a complaint you might still give nitro to that doesn't?
I'm thinking someone who might be actively bleeding.
Are you saying, I'm going to give somebody who is actively bleeding nitro? Is that what you're saying?
I'm thinking that, yes.
That's going to kill them. We're laughing. It's not funny. Why now? Tell me why giving somebody nitro that is bleeding might kill them.
Might cause our heart to reduce preload, which would eventually put them into shock.
Yeah, that might work. I mean, if I've got a garden hose and I'm watering a plant and I cause garden hose constriction or vasoconstriction and I'm pinching that off, less water is going to come out, right? Whereas if I dilate that garden hose, a bunch of it's going to come out. In fact, if I cut Peyton's arm off, essentially, if I do it cleanly enough, it'll have massive vasoconstriction. It might not bleed much at all because it's doing good vasoconstriction. Now, if it didn't, if instead it vasodilated because I gave her nitro, now what's happening?
More blood's coming out.
Right, absolutely. More blood's coming out. So why might it be dangerous? And almost considered probably a contraindication if somebody was actively bleeding to give them nitro.
Because if they're actively bleeding and you dilate blood vessels, then a lot more blood's going to come out.
Love it. Good job. Love it, love it. All right, we talk about the dose here for this. Where are we at? Destiny, we've got 0.4 milligrams. What does Q3-5 minutes mean?
Check every 3 to 5 minutes.
Sure. Hey, how's your pain doing? Better or worse, right? Oh, it was a 10, now it's an 8. Oh, it was severe, now it's moderate. All right, let's give you another. What do I need to know before I just keep giving them every 3 to 5 minutes?
You have to keep checking their vitals for their blood pressure.
Absolutely. Also, have you taken an ED drug in the last 9 minutes or so?
Right.
Like when I wasn't looking, sneak one in, you know? It's pretty nurses, you never know. Okay. Now, why don't I say, Courtney, why don't I just say hypotension here is a contraindication?
Because hypotension is at 90. I believe.
Bam,
So
right?
technically,
Yeah, I appreciate your hesitance there. I am okay. If an adjunct says, I took points off because Courtney said that she was concerned about a 92 blood pressure, concerned about a 101 blood pressure, and that's well within the scope. I'd say, yeah, I think you're right. I'm not going to probably lower that point. If she's hesitant about it. She said, oh, I'm a little hesitant about aspirin based on his heart rate. I'd be like, okay, fail that nerd. What are you talking about?
no, I like aspirin.
Yeah. So the nitro thing is there. Now, okay, Amanda, we're talking bradycardia. Why on earth would bradycardia have anything to do with nitro? Why is that even a thing?
Slowing down. Slow heart rate since the preload is reduced.
You do know how to explain.
Yeah.
You're doing it perfectly.
Okay.
Yeah.
But since the preload is reduced, that blood's not going to move.
Because we know what you're describing is a formula. What formula are you describing?
I don't know.
CO,
It's cardiac output.
right? Which is what times what?
Stroke volume.
Very good, which is going to largely incorporate our preload and
Heart rate.
so if our heart rate is low, then it's naturally going to take down our cardiac output. So if I've already got a medication that's lowering preload with bradycardia, dude, that guy's doomed. He's Dune. Very good. Very good job. Very common, essentially, to see descriptions about headache. Nadia, why would I expect hypotension here with this med?
Because we've opened up everything.
Bingo. Yeah, like a guy getting stung by a bee when he's allergic to it, but right? For sure. Why, India, would a guy be dizzy?
Less blood flow.
To
Brain.
the brain. I love it. In fact, why then am I saying you should be asking your patients questions that are not in sample? Questions like,
Are you dizzy?
because it might mean,
You shouldn't enter the med or it's having adverse effects.
or you're not getting blood flow to your brain. Right? So a guy says, I don't know, I'm a little lightheaded. I mean, a lot of people are like, okay, we'll check it out. It's like, hey, lightheadedness means not enough blood to the brain, or the two primary things it carries, which is
Oxygen and sugar.
oxygen and sugar, right? Oxygen and sugar, which is why we should be asking ourselves, like, hey, this guy looks shocky. Is it oxygen or sugar, or maybe just the blood in general? Right? We are adding this to our repertoire. What does TD mean? Transdermal, right? All right. So let's take a second. I want to lay out our little puppy pads here, and we're going to try to work over this puppy pad. I don't know if it's wholly necessary, but we'll see. And we're going to kind of goof around with some transdermal nitro. It is probably real nitro, so I brought gloves up. You don't want that on your skin, or you might get lightheaded and hypotensive.
Yeah, I'm good. I already have two.
Yeah. I mean, if you pass out, you are still expected to stay in class. So.
It won't be moving.
Hi.
Yeah.
Volunteers attested.
Yeah.
No.
All right. One of the two of you needs to take your shirt off. No.
Passing out is not a fun
Why not
experience.
both?
Okay.
It's orientating. Your kid would not recommend.
Don't move it yet. Another slide on here. It's crazy. Like here it is, 11 o'clock, right? And before I started this, I was like, they know so much of this. Am I going to have enough to talk about? And I'm like, we're in our first of like 16 meds, and it's almost midnight. I keep, no, I take notes from, oh, next year, this is where you were at this point. So, for example, and 30 minutes max. Make sure you move through this and that. No quiz, so you guys. I don't know. You know, in my mind, I was like, dude, where am I?
Please, either.
What dizziness? Chirp, 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 chirp. We need to go over it again. All right, brother.
Do you need me for anything?
Thank you for so much. Nitroglycerin is transdermal patches. What you'll see here on the left, these are what do you call them? Prescribed. This is what they might look like. We definitely need to be in a world. We did in EMT, we all the more so now need to be in the world of checking for these patches. You would not believe the amount of times that a person is like, I don't know why my mom's dizzy. I check all the vitals, I check her heart. I'm like, I don't know either. Just do a quick physical assessment. Poop up the arm or whatever. I'm like, oh, I found a patch. I'm like, oh, check the other one. Oh, there's a patch. Check back here. There's a patch. I'm like, sweetie, you need to take these nitro patches off at the end of the day. You don't just keep applying. That's you're just infusing nitro nonstop, or fentanyl, or whatever. So it's part of the reason why we do these cursory physical exams for them. Now, where you'll likely see it in the field is either in this tube or in this little packet, much like we have the packets. Again, be careful here because this is probably real nitro and probably still works. No one is going to fentanyl pass out from it, but it's best to keep it off of your finger. Now, I have I don't know, about expiration stuff, but if you down them, I mean, it might.
I wanna see what happens.
I will say this, I mean, I kind of do too, but I will say this, it would probably have to be buccal because I don't think that at this point, even up to date would cause any effect really. Here's the truth of it, guys. We talk a lot about vasodilation and stuff. You don't know a dirty little secret or whatever? Is that we will largely only see major blood pressure dropping if it is more nitro than you have available to you, or if they have a very specific right-sided heart failure or infarct. It is, in fact, very rare, I think, for someone to give nitro and watch their blood pressure plummet. But we don't train according to probability. We train according to possibility, that it can happen. But realistically, Anyways, as you can see here, basically what happens and what we'll be doing here is our doses for this. Now, truth be told, the dose can be, based on protocol, can be upwards of like 5 inches of it, but we're just gonna learn 1 inch of nitro. What we'll be doing essentially is just tearing this open, and then as you can see it's listed in inches. We'll just be putting a line or a smear here. You might be asking like, how thin, how much? I don't have an answer to that question. We measure it in length, not width, but I would just essentially tear it all the way off and smear it down to 1 inch. So let's just take a second and do just that. Let's open up the nitro packet and smear it approximately 1 inch down the patch. And so you'll only need to just tear the end there. You shouldn't need to like tear open the whole thing. You're fine. I just mean, I saw somebody essentially like peeling the whole thing wide. Mhm.
This is fun.
Yeah, it's possible that it. No, that's all right. Yeah, that's fine.
It's not wanting to.
Yeah, there you go.
See it?
Cool. Very good.
I'm a professional.
Yeah. See, you've done this nitro before.
We're just doing
So
an
what's
inch.
that dose?
Yeah, just did it.
Well, we both did an inch, I just saw this.
Gotcha. Yeah, I like it. Okay, like that's twice the dose. Now, admittedly, again, I've seen protocols before. It was up to 5 inches and stuff. I am very comfortable just telling you guys 1 inch. Just don't be surprised if you see like a registry question that says like, "What do you want to do here?" and the dose is like 2 inches. Don't be like, "That's not the dose, dude." It can be upwards of 5. It's whatever. Now, as you can see here, this is placed on the arm. I will admit, I've only ever placed it directly over the sternum. If it's transdermal, that's close to the heart, so I just plopped it right there. That's where every protocol I've worked with, but I've never done any research as to why one might be better than the other, except for 2 points. Number one, your chest doesn't move a whole lot outside of breathing, whereas the arm can move all over the place and it's more subject to falling. How we're going to do this is if you are going to apply nitro, let's just assume that it just goes right over the sternum, essentially the place you do CPR, okay? And that if in fact you now needed to do CPR, you would just take it off and you would wipe it off. In fact, that's one of the best benefits and why I was so surprised that it wasn't part of the EMT scope, is that unlike nitro, where I can't go into your body and pull it out, what do you do if they start becoming hypotensive and you've got nitro paste on? Right? Just a quick lick, look, gone, right? You can just wipe it off if it's not working out. I'm like, how is that not an EMR skill for crying out loud? You just wipe it off. I wish every drug worked that way. Just pour a little fentanyl on your head and then dab it off if it's too much, right? So that is in fact going to come as either a test question or a scenario where unless you remember to peel it off and wipe it off, then they're just gonna keep getting worse and worse and I'll make you do 10 minutes of CPR, you know? So make sure that you remember on one of the rare few medications we can actually take back that wiping it off is an important case here. All right, Ray, what do you got?
Hey, so are we, like in the field, we would actually be putting this on this piece of paper and then putting it on the skin?
That's correct. You, essentially, if that puppy pad was a chest, you'd just be flipping it over.
Got it. So we're not, this doesn't, we're not.
That goes into the garbage and this. I will say, what has always kind of been my conundrum is that, like, we do this, right? But I'm like, this thing is largely empty, right? So in my mind, you should make a package that just tears open, and then you just put the package on there.
Thanks to
Kind of like the inclusive
Since you're
dressing.
bringing down our idea,
I know.
go for
Cover
it.
it. I don't know why they don't do that, but that's what happens.
Because logical people are not sitting at the round table.
Just put this on the skin itself.
To protect it. Because what happens for sure, even this patch, you'll see in nitro patches, like you'll turn over care at the hospital and it'll suddenly be lateral, and you're like, at what point did somebody brush up against that? And if it was just medication, they'd be wiping it off. So this, all you do here, now this guy's got tape on it. I have never taped it. The nitro keeps them stuck pretty good, but the paper is to protect you from wiping it off.
Okay, yeah. So,
And as a way of measuring it, I guess. So here it is on the arm. My guess is that works fine. My expectation is that you'll put it on the chest, but I don't think anybody will get marked wrong as long as it is on a flat surface area. It will just be weird, right? So that's where we're at for that. All right. Do I want to do anything else with that? Oh, when are we doing this? When am I doing transdermal nitro paste? Basically, if they're on CPAP, right? If I suspect pulmonary edema, could it be used for chest pain, non-traumatic chest pain? It could, but the tab and the spray are way more effective, they're way less messy, et cetera, et cetera, et cetera. So our expectation, or my expectation for you is that, oh, hey, this guy's got pulmonary edema, tab of nitro or spray of nitro, let's get him on CPAP and get that transdermal going. Okay? Guys with gloved hands, if you just grab that crap up and toss it in there for me, that'd be cool. Just so we don't have nitro sitting around. India, what class is aspirin? Also, I'm not faulting anybody if they say the action because you don't know how to differentiate them. I don't care.
Non-steroidal, anti-inflammatory.
Okay, so it's an NSAID. Very good.
I was gonna say, class 5.
Class 5, what does that mean?
Less likely to form an addiction, less addictive.
Oh,
That's like-
as in like
That's where I was going,
I
that's what I
see.
read.
antiplatelet as well, yeah. That was what you were gonna say? What does antiplatelet mean?
It is, it helps the platelets slide, move.
Sure, I'm okay with that. It doesn't bust up clots, right? It merely prevents them from getting bigger. Right? It antiplatelet aggregate, we'd call it, right? Very good. Tony, you've got a patient who is complaining of chest pain. Do you give them aspirin?
Yes.
Okay. Do you want to know anything before you give them aspirin?
Have you been bleeding for about 3 days?
Why are you asking me about bleeding with aspirin? It's not a blood thinner.
No, but it's an antiplatelet.
So if I cut Destiny's arm off and I give her aspirin, what might happen?
She will have a clotting issue.
Meaning what? Too much or too little clotting?
Too little.
Too little, so she will
Not clotting.
die like a sissy, right? All right. Very good. Chest pain, non-traumatic, discomfort. What's our dose?
324 milligrams per
4,
ml.
very good. Hypersensitivity. Let's remember, I think I didn't hit this very hard, hemiplegia, right? What is hemiplegia?
One side
Apparently I
of
didn't
the
hit it at all.
body
Right,
Is.
not hemiplegia. Oh my goodness,
Okay.
hemophilia.
I know.
That's
I was
what-
like,
Wait a minute, I was like, what?
You guys don't know about partial neurological deficit and aspirin?
I was so confused.
What's
I was
wrong
like,
with you?
But the bleeding.
Sometimes I feel like nobody appreciates the neurovascular effects of aspirin. And, okay, obviously hemophilia, that's a mistake. Make sure that you know, I was like, whoa, I really didn't teach this then. Oh wait, that's the wrong word. Hemiplegia, or hemophilia rather. I just
Numbness
didn't.
and tingling on half the body, or is that yeah?
Yeah, well paralysis, whereas paresthesia might be more the tingling, but you're
Oh, okay.
very, very close.
Okay.
Anyways, it is a clotting disorder. Admittedly, I just told you everything I know about it. But it means essentially if you've got a disease process where it's already hard enough to make clots, giving you aspirin is going to make that even harder and therefore considered contraindication. Asterisks. If your patient is having an active heart attack and complains of a stomach ulcer, a bleeding stomach ulcer that the doctor is monitoring, can you give that patient aspirin? Let me rephrase. Should you?
Well, yes, if they're.
Your answer, we'll say it together, is no. Because why?
The bleeding.
Because it is a contraindication.
That's right.
Did I do it 1,000 times in my job? Yes, I did. But I did it out of scope and protocol. If I'm wrong and this person bleeds to death because their doctor didn't say it was a stomach ulcer, they said it was a AAA, and I gave them aspirin to fix their heart attack. It wasn't a heart attack, I misread it, and now they're dead, I go to jail. Because they're gonna say, he said bleeding, and you gave it to him. So get into your head. It's a question of, do I give this med? Is it indicated? Is it contraindicated? Simple binary question, plus or 1 or 0, yes or no. And if in your clinical experience you say, look, your guy said you said stomach ulcer, you haven't been vomiting blood, you haven't been diarrhea in blood, your blood pressure is fine, I'm gonna go ahead and give you aspirin because I think you're having a heart attack. That's still wrong. How could I give this person aspirin even though they have a contraindication? How could I do it correctly and legally?
Med control.
Med control. hey doc, I got a guy says he's got a stomach ulcer here, but I see no external signs of that, and his vital signs are all good. I'd really like to go ahead and get him aspirin. We're 40 minutes away, probably better than not. That doc's probably gonna say, what the hell are you calling me for? Of course do that, but that's still the right way to do that.
That way you cover your butts.
Cover your butts, that's correct. Yeah. 23%. King and I read the same article. He interprets it as 75% reduction. I think he's wrong. Or 77. I think he's wrong. So. What is aspirin? We talked about this a bit. It is antiplatelet. It is not a blood thinner. Now, where this comes into play is you are turning over a stroke patient, and they say, are they on any blood thinners? And my answer to that is no, but they do take a daily aspirin. It's good to know. Does it say antiplatelet? It's not technically a blood thinner. It doesn't usually interfere with the stroke process. And specifically, what they want to know is, hey, can I give a thrombolytic to this guy? Because if he's already taking one, I can't do that because he's going to die of blood loss instead of correcting his head issue. If you say, yeah, he's on a blood thinner, then they might delay care, whereas what you should be saying is, well, so anytime, the point is anytime a doctor asks me, I told him the medications. Is he on a blood thinner? Well, he takes aspirin and Brilinta. He's like, oh, okay, one of those is a thinner. Whatever. People have different interpretations. So I just list back the ones that are antiplatelet or coagulant or thrombolytics and stuff like that. We won't go too much into this. This is just how aspirin talks about platelet aggregation, aggregate being the chunks building up, right? And about how fibrin and these kind of things work. We'll get into that. I don't know that we'll get into that, but we're not going to talk about it now. Aspirin is an anti-inflammation medication. It's an NSAID, but it's not specifically listed as an analgesic. Why then do we give it for chest pain? It could be a heart attack, but it's not an analgesic, but I give it for pain.
But they're causing the pain.
Because it's the clot, it's the platelet aggregation. That's why I'm giving it. Right? Percocet, for example, is an analgesic. It's a combination of two different meds, right? It's got oxycodone and acetaminophen. Acetaminophen now in our scope. And acetaminophen is an analgesic. It is something that we're giving specifically for pain. Would acetaminophen benefit me if I was having a heart attack?
No.
Why? Why would reduction of pain benefit a person having a heart attack?
Oh.
Blood pressure,
Why blood pressure?
because it goes up when you have pain.
That's
Or
right.
Right.
Consider that.
I know.
Consider that everybody just like devastatingly injure their partners right now. Okay, wow, very quick today. You know, when you're in pain, your heart rate goes up, your blood pressure goes up. It's a sympathetic response. You are requiring more from your heart, more oxygen demand on your heart, so the reduction of pain is beneficial. In fact, it's why a lot of chest pain protocols, the medics will give fentanyl. It's not an antiplatelet, but it does reduce pain. And if you're just like, dude, I think I'm dying of a heart attack here, your heart rate is probably nice and easy, which is great, right? So, what I'm not saying is give Tylenol to every chest pain patient, but I am saying it's not crazy. It's not crazy. It's also an antipyretic, and that's mostly what we're giving Tylenol for. In fact, I'd be a little surprised if any of you ever work anywhere that you weren't just specifically giving Tylenol to pediatric fevers, full stop. I'm going to teach you adult dosing, IV dosing. I'll be a little surprised if you ever see it in the world. Oxycodone is an analgesic, but unlike acetaminophen, that's mostly on the protoglastin, essentially, is an opioid. It binds to different things. It releases different hormones and so on and so forth. But they're both working together. The question comes into play of like, why both of these meds? Why an opioid and an antipyretic analgesic? Why both of them? That's correct. That's correct. And we'll talk a little bit about pain threshold here. So here we are, fine and happy with no negative stimulus, essentially, and here we are above our pain threshold in great pain, right? What I'm saying here is that if sensory hits us, like if I'm walking on the carpet, this is stimulus, but it's not enough, right? I mean, does anybody like their back scratched? Feels good, or whatever the case is? Imagine I'm scratching you with pieces of glass. That's way worse. So a back scratch goes from minimal stimuli to major stimuli, and your body will interpret that as danger. This is death. I'll bleed if you give me too much stimuli like that, right? So minimal stimuli here, well below the threshold of pain as we would describe it. If I step on a nail, for example, suddenly that pain spikes above it. It says, hey, I am now receiving sensory that is way up here, something needs to change, right? And in fact, we interpret that in our brain as a painful experience, ouchie, right? So one of the things we can do to affect this is we can give Tylenol, and how Tylenol works in a sense is it goes to our hypothalamus, it reduces the release of hormones that help us interpret pain. So it's almost like, if you can imagine right now, you saying, you know how, what do I want to say? They went across the country and they wanted to test people's pain thresholds, right? On a scale of 1 to 10, what is getting hit by a car? What is, slamming your finger in the door? And of course, they found that everyone's threshold was different. Some people were like, paper cuts are the worst, and some people were like, I mean, I've slammed my finger in a door, it was only a 5. Other people said people's pain thresholds are different. They have more or less hormone release, more or less reception of those hormones. People feel things differently, right? Tylenol, for example, if there is a hormone that says, hey, you stepped on a nail, go up and tell the brain to release this chemical and get stuff going, Tylenol reduces the release of that prostaglandins. And so what happens is it actually increases our pain threshold. If before I had 10 chemicals released to tell my body I'm in pain, Tylenol is now saying, hey, only release some of those. So now only 5 go out. So your threshold is higher. I'm still in a little bit of pain though, because the 5 that were released, it's a lot better than the 10 that were released, but the 5 that were released are still binding and still causing an issue. Now, if I administer a fantastic pain reliever, like black tar heroin, right? That will bind to our opioid receptors and cause dopamine release that will actively work against pain and pain receptors. It will also block certain receptors, preventing the experience. And so if Tylenol is kind of raising our threshold, right, making it so that we just feel less, things like opioids are literally binding to certain receptors to forbid that. So they work in tandem. One raises the threshold, one minimizes the pain, and that's how we get below that. Because we found that, of course, you take enough heroin or fentanyl or Percocet, or whatever the case is, enough opioid, we can take the pain all the way down. But that has a ton of other side effects, right? Like respiratory depression, among many things, not the least of which is addiction and so forth. So we can give you, it turns out, just a little bit of opioid and Percocet and a whole bunch of Tylenol, and they can work together to kind of make it so you're not taking a bunch of opioids, and that's how that's working, right? This chair got to go, I'm gonna die on it. Now, we aren't gonna go much into depth here either, just a quick review about nervous synapses, right? You have to remember that we have all over our body, and I suppose that's what that picture ultimately was for, all over our body, in our spleen, our stomach, and our veins, our arteries are everywhere. We have all these different shapes of receptors waiting for different chemicals to hook to it. Like a million different locks with a billion different keys waiting for the key that affects it, right? And so this stuff is flowing through. I inject heroin into my arm, it floats through my body, down my vein, because my vein has no opioid receptors until it reaches an opioid receptor in somewhere like my dopamine release or in my respiratory center, and it'll start binding. So if I've got these little grabby hands hanging off my organs or nerves or wherever they're at, these are my receptors, of course, and I inject black tar heroin, and the horse comes in, and maybe that molecule binds to the receptor, it's then gonna start causing an effect, right? If we say, well, there's an opioid receptor and heroin binds to it, it's gonna cause this massive stimulation of chemicals to come out, some feel-good stuff, some breathing suppression stuff, a bunch of stuff's gonna pour out, much like this piñata. Once it binds, it's gonna pop and release all kinds of chemicals. The metaphor breaks down a little bit because, of course, the molecule isn't breaking down necessarily, it's instigating a different reaction, but that's kind of the point. Like we discussed, reducing pain signals, it gives us the feel-good chemicals, all these kinds of things. What's our counteractive agent for opioids?
Narcan.
Narcan, right? We give Narcan, Narcan's gonna come in and bind to receptors, preventing heroin from binding to it. And it will also muscle out the opioids that are already bound, right? We will talk, well, I don't know. Quick reference, if nothing else, the difference between agonism and antagonism. These are both active processes. What we shouldn't say is antagonism means nothing happens, agonism means something happens. No, they're both something happening. Agonist will largely bind to a receptor to cause an effect, right? If heroin binds to a receptor, it will make me feel good, stop me from breathing, that's an effect. Whereas an antagonist would be, it binds to a receptor but does not allow an effect to occur. So an antagonist, like Narcan, is going to bind to this receptor and what? Make me feel good? Make me have it? No, it's mostly going to prevent anything from happening, and that's why we call it an antagonist. Now, this is a deep rabbit hole. There are many types of antagonists and antagonists. There are medications that antagonize without binding, some that bind but do nothing. But superficially, this is what we're talking about. Anti-agonists. All right. Now, we talked about Narcan a bit in the past. We know our intranasal dose, that's largely where we started, 2 to 4 milligrams, both adults and pediatrics. We now give Narcan, or can give Narcan, basically any way you can put it in the body. In Flint, when I started, we used to give it sublingual, I think intralingual, it might be the term, I don't remember. We'd pull a guy's tongue up and stick a needle under his, and just inject it there.
That hurt the morning.
So IV, IO, IM, I mean, realistically, any way you can get Narcan into the body will probably work, but ideally we're looking at probably IV cases here. And our dose for both adults and peds is 0.5 to 2. I didn't bring it up, I don't think, but most auto-filled syringes or pre-filled syringes have 2 milligrams in them, which means you're usually just giving some of that. The culture, and what I'd like for you, is for us to give it in 0.5 increments. That's what I'd like from you. Mm-hmm. My guy is in the bathroom of a Publix. He is passed out. Maybe he has pinpoint pupils, maybe he doesn't. I see no signs of trauma. I'm starting to wonder if maybe he didn't take something he shouldn't. Because he's not breathing, I'm now going to give Narcan. You could give it intranasal, but in my culture here, I'd rather you start an IV and give it IV than intranasal. Why is that?
It's stronger and
It's more effective and it's faster, stronger, essentially. Absolutely. Start a line, throw it in Narcan. I'm okay with that. Okay? Both are good answers. Both are technically correct. I'm going to give an intranasal 4 milligrams while we start an IV. Sure, I'm okay with that. But no, I don't do that. Because just of how long it takes and how anecdotally, how rarely I've found that effective. Whereas 0.5 in Narcan is like a lightning bolt IV. I mean, it is instant. Have you guys seen yet Narcan working in the field? Mm-hmm. No, not so much? Maybe in your personal life? I don't know.
I had a drug overdose once. I saw it in the field working wonders.
Yeah. Can you testify to the fact that it was like instantly reversal?
It wasn't really instant. They were still BBMing him when we got him loaded. They started.
Oh, but they did intranasal. Is that right?
Yes.
That's my point. Is numerous times I show up, fire's bagging a guy, and they say, we already gave 4 milligrams intranasal. And I'm like, okay, I'm going to start an IV. And then I'm going to give 0.5 Narcan. And as soon as I do, they're like, I didn't do drugs. Okay. Okay. Cool.
It's like, thanks for that. Cool.
It's not your job to discover what they took. And unlike many EMTs and medics say, they don't have to tell you what they took. Also, I would say, I hope that you leave this class smart enough that if you gave an opioid antagonist and they're breathing now, you know what they took.
Mm-hmm.
If a guy says, if he says, well, hey, I'm going to take a handful of benzos or Xannies, and then passes out and breathing is affected, I'm going to give Narcan. But it's probably not the right registry answer. Also, they're not going to give you like 2 right answers always, even if it looks like it. Meaning, if it was like, Peyton says, hey, I'm going to take a bunch of benzos, and then stops breathing, and my answers are something like do nothing, bag, or give Narcan, I'm going to pick bag because Narcan's not for benzos, and it's a good option anyway. You see what I'm saying? However, as clinicians, I don't mind you running a scenario and trying Narcan even when you don't suspect opioid, simply because you see the respiratory depression. I'm okay with that. Incidentally, Mr. Dennert disagrees. He's more of an opioid suspicion guy. Why would you give Narcan if it's not narcotic suspicion? And I'm like, screw that. So what I have experienced is time and time again is saying, hey, they took a bunch of Xanax, so I didn't give Narcan, and the doc's like, cool, let's go ahead and try Narcan. Because if you're gonna take something, you might take something else. Also, people who are overdosing aren't usually super meticulous on, oh, is this exactly what I'm supposed to take? You see what I'm saying? So I'm okay with that either way. By definition, you'll maybe see in your book or out in the world that it's 0.1 milligrams per kilogram for pediatric dosing. Does anybody have any idea why I do not teach that? Let me ask you this. I have a 30-year-old who overdosed on opioids. I start a line and give Narcan. How much do I give? 0.5, very good. Now let's say that it's not a 30-year-old. Let's say it's a 3-year-old. And I'm giving 0.1 milligrams per kilogram. How much am I giving? Well, a 3-year-old weighs how much?
Roswell tape or whatever it's called.
Hand heavy, baby. Let's hand heavy. Everybody's hands up. Boom. 1, 3, 5, 7, 9, 10, 15, so 1-year-old, 3-year-old, 10, 15. How much does the average 3-year-old weigh? 15 kilograms. 0.1 milligrams times 15 kilograms is? So you give 3 times the dose to a 3-year-old that you give to a 1-year-old. The point is we're talking Narcan dosing. I have looked for it. It is possible they need more Narcan than we do. It's possible. But until I know that, and I don't know that, I'm not teaching that. What that means is people under 6 months is who you're doing the math on. What the hell are we doing? Why are we teaching Narcan at 0.1? You see what I'm saying? I mean, think about it. A 1-year-old is 10. That means a 1-year-old gets twice the dose of an adult loading. Pass. There's in the back of my brain somewhere where I thought I remember an article saying that kids just need more. Until that day, easy math. 0.5 for everybody. Okay? Is there any problem with giving too much Narcan? You say, dude, why give 0.5? I'm just going to give 2. Is there any problem with that?
Aggressive and throw up.
Consider that you're putting this person in a withdrawal. And going through a week's worth of withdrawal in a moment is not awesome. So I've heard. So there is a problem with that. It can make them more aggressive. There's also a problem with the rate at which you push it. There are rare instances of people pushing too much or too fast and causing a dysrhythmia. It's rare, it's possible. Also pulmonary edema. Flash pulmonary edema we've seen happen. Again, the point is give the 0.5 dose, give it over 20 seconds or a slow IV push or whatever the case is, and you'll be fine. Don't be a D-bag and pound 2 milligrams of Narcan into a dude to ruin his day. Don't do that. Also be careful. A lot of medics will say, hey, he's not having a lack of Narcan, he's just not breathing. Let's go ahead and bag him. Why is that a problem? Good, that's right. Because bagging somebody is not a harmless intervention. It comes with a bunch of complications. It's a ton of work, it wears you out, barotrauma, tracheal issues, all kinds of crap. What's it called? Emesis? Aspiration, all kinds of stuff. Whereas I give you 0.5 of essentially a harmless drug and now you control your own airway, that's what I want. Right? So again, make sure as students you're kind of hearkening to the master there, but when you're a clinician, you make your choice. So you get to pick your poison here now as we're finding as AEMT. Maybe India says, I don't really like that I have to go through the process of starting an IV and when I can just instantly do it nasally, let's just do that. I'm okay with it. You get to make some choices here. It'll be very rare I write a lab where I say, and then they suddenly got better from intranasal Narcan. So you need to have the wherewithal to say, well, even if that's my thing, I do intranasal Narcan while we're setting up an IV. You have to have the wherewithal to say, well, the intranasal didn't work, so I either need to do more or go to IV or IM and IO. Now, I will say a case about IM. I rarely did IM. The absorption rates are faster for intranasal than they are for IM, so I would say we're probably only ever giving this IV or IM, probably. But you can give it anyway, really. Where this might come into place is we're now knee deep in a cardiac arrest where a 20-year-old overdosed on heroin. We finally got his heart rate back. No one could get an IV onto him because his blood pressure was 0 and he always shot up his own veins really bad. So now we're giving it IO instead. That's where that would probably happen. But it's rare, I would say far rarer. All right, so let's just take a moment and answer these questions with your partner. Both, who should I be giving Narcan to? Who shouldn't be giving? We be giving this to? What is the IV dose for an adult, and what is the IO dose for a 4-year-old? Go.
You don't have the indications.
Oh, there's some kind of food thing happening. Do we know about this?
Oh yeah, like 12 or something.
I think it might even be.
I think, yeah, because I read in like.
Let me look. Keep going. Well, I don't know what I'm talking about, but I was like, wait, the 11th. This is like a lunch.
Yeah, I think like some of the food stuff was married on campus. I know there's like something. Yeah, there was something that was going on there.
truck or is it the top of the truck?
I don't know. I know it was like one.
I feel like it's not, because Mr. Denner was bringing it up again, and we universally laugh at that stuff where it's like, hey guys, come spend your money at this place instead of that place. Why do we care? So I think it might be something different.
I think it's like one of those. I think there's like something at some point for like a hot chocolate or whatever where you get like free hot chocolate, a t-shirt, or something like that, because I'd taken a picture of it. Yeah, from 10 a.m. to 12
Where at?
in the North Metro Student Center.
What is it for?
It's like the welcome back warm up, and you can get like hot chocolate. I think you get a t-shirt if I remember correctly from the email. But 'cause I literally like just took a picture of it when I was checking my email, and I was
Perfect.
like, ooh,
So let's do this, gang.
hot chocolate.
We'll take a like an hour and a half lunch or something. Like we'll be back at 1300. But let's just go let's go as a family now. We'll just walk over there,
Yeah,
see what they
go
got
to
going
get hot
on,
chocolate.
and then we'll come back at 1300 in the classroom. Okay.
So what are we doing?
We're gonna go. Is it the A building probably?
Probably because it says student center, so I'm assuming
Yeah, so that's A
A.
building. So they're doing some kind of hot chocolatey welcome back thing that maybe we can get swag or.
Yeah, because I think that they
Whatever.
said that they were
So-
giving away like a free t-shirt or whatever.
You don't have to go. What I'm saying is hey, we're gonna go to lunch. We'll come back at 1300, but we should go over there and just see what they got that we can see.
Let's do it.
Because I'm reading, so.
Yeah, exactly. Just like mine.
So we'll touch base on the Narcan stuff. I just don't. It's already 30.